Welcome to the Hearing Review's webinar, Depression, Hearing Loss, and Treatment with Hearing Aids, presented by Bray, PhD, and sponsored by Hamilton Captel. I'm Carl Strum, editor of the Hearing Review magazine and its website at hearingreview.com. In the past decade or so, you've probably heard a lot about hearing loss and its association with things like cognitive decline, dementia, depression, and a raft of chronic disabilities ranging from diabetes to heart disease. In fact, last year we hosted a very popular webinar and white paper by Dr. Harvey Abrams on this topic, which was also sponsored by Hamilton Captel. But our webinar today takes a deeper dive into how hearing loss and its treatment might influence depression. People in hearing healthcare tend to explain to patients or whoever might listen that hearing loss can lead to communication difficulties and breakdowns, which lead to social isolation and loneliness, which can ultimately lead to depression. However, as we'll see in this webinar, the picture isn't quite that simple. In fact, it's rather complex. Dr. Bray is going to take us through some of the most important research related to hearing loss and depression, and I think what you'll gain is a much more nuanced picture of those factors surrounding hearing loss and depression, how treatment with amplification might help, who it might help, and what you can do to screen patients and refer them out for depression. Dr. Bray is a PhD audiologist and an associate professor and the former dean of Salus University's Osborne College of Audiology. He was previously the Vice President and Chief Audiology Officer of both Sonic Innovations and Otokinetics. His research interests include amplification technologies, comorbidities in audiological medicine, and scholarships of teaching and learning in audiology. He is active in several professional organizations and is currently the Secretary-Treasurer of the National Academies of Practice and is on the Board of Directors of the Audiology Project. Dr. Bray is a third-generation hearing healthcare professional and thus has experience in many different professional settings, and he has been recognized for his work and is a recipient of the ADA Goldstein and Wernick Awards, the HIA Volunteerism Award, as well as the UT Austin Outstanding Alumnus Award. Our webinar sponsors Hamilton Captel. Since 2003, Hamilton Captel has connected individuals who just can't hear on the phone with family, friends, and healthcare providers. The experience of being able to read while listening to what is being said on the phone provides clarity and confidence, which is why so many people with hearing loss rely on Hamilton Captel caption telephones to stay connected and stay healthy. Right now, through the Hamilton Captel Hearing Healthcare Program, you can certify your qualified patients to receive a Hamilton Captel phone at no cost. For more information, call 800-826-7111 or visit hamiltoncaptel.com/HHC. As a matter of housekeeping this webinar, you can email Dr. Bray and me questions at any time via the Q&A box on the left or by using the email address shown at the end of this presentation. I'm also obligated to point out the standard legal disclaimer, which essentially says you are urged to consult with financial, legal, and other advisors relative to this content, and there's no implied liability for the use of this information that's provided. And with that, Dr. Bray, let's get started.
Hello, and welcome to the webinar on depression, hearing loss, and treatment with hearing aids. I hope you find this webinar informative and enjoyable. I also hope that the information provided may motivate you towards new considerations in your treatment plans for persons with hearing loss. The specific topics that we will address today include the major problems associated with untreated hearing loss, the major improvements associated with treatment of hearing loss, a review of recent investigations into untreated hearing loss, treated hearing loss, and depressive disorders, some considerations of hearing loss and other chronic illnesses, the psychological conditions of depression, anxiety, loneliness, and their interactions with hearing loss, some emerging discoveries linking physical health and mental health conditions, and the current guidelines for screening for depression in healthcare facilities. What are some of the problems associated with untreated hearing loss? In a publication on the negative consequences of hearing impairment in old age, Strawbridge and colleagues evaluated data on almost 2,500 adults participating in longitudinal tracking process. They specifically looked at the association of hearing loss on activities in daily living, instrumental activities in daily living, physical performance, and mental health. They found multiple negative outcomes and diminished functional status associated with hearing loss, including depression, loneliness, and altered self-esteem. They attributed this to a sequence of events whereby hearing loss reduces the ability to communicate, which negatively impacts interpersonal relationships. From the large database, they were able to calculate the adjusted odds ratio for the impact of moderate or greater hearing loss and found increased odds ratio of approximately 2 for disability in activities in daily living, physical performance disability, fair or poor mental health, and depression. What are other problems associated with untreated hearing loss? Stig Arlinger published a review on the negative consequences of uncorrected hearing loss. His findings included the following. Uncorrected hearing loss represents an auditory disability involving speech recognition ability, especially in difficult environments, and reduced ability to detect, identify, and localize sounds. This affects the life of both the hearing-impaired person and significant others, and the hearing-impaired person is not always aware of all of the consequences of their hearing loss. Further, he said, uncorrected hearing loss is associated with a poorer quality of life related to isolation, reduced social activity, a feeling of being excluded, and increased symptoms of depression. There is a significant correlation between uncorrected hearing loss and reduced cognitive function, but there is no clear proof that hearing loss is the cause of the reduced cognitive function. Now for a bit of background information. In this webinar, we'll be looking at the relationship between hearing loss and several psychosocial measures. What you see on the slide is a list of many, but not all, of the psychosocial measurement tools used in studies. A few of these that are more commonly used are highlighted, and I will refer to them using the initials. BDI is the Beck Depression Inventory. GSD is the Geriatric Depression Scale. HHIE is the Hearing Handicap Inventory for the Elderly. MMSE is the Mini Mental State Examination, and SELF is the Self-Evaluation of Life Function. Now that we have looked at the impact of untreated hearing loss, let's review what we know about the effects of treatment for hearing loss. A major study that I'd like to review was a publication by Mulrow and colleagues on the quality of life change in hearing impairment, a randomized trial. The study started with a screening of 771 possible subjects and was filtered to a study sample of 194. One half of the subjects were assigned to a waiting list, and the other one half of the subjects were assigned to the hearing aid treatment group. The two groups were assessed against each other over time. Some major findings were: at baseline, 82% of the subjects reported adverse effects on their quality of life due to the hearing impairment, and 24% were depressed. At 4 months follow-up and compared to those assigned to the waiting list, a significant change in score improvements for social and emotional function, communication function, cognitive function, and depression were seen in subjects who received hearing aids. This field trial established that hearing aids are successful treatments for reversing the social, emotional, and cognitive dysfunctions caused by hearing impairment. In a follow-up publication on the sustained benefits of hearing aids, Mulrow and colleagues published their evaluation of the 192 subjects at 4, 8, and 12 months after their hearing aid fittings. Quality of life measures for social and emotional benefits, communication benefits, and depression benefits were sustained at 8 and 12 months, whereas the cognitive benefits were not sustained at 12 months. A second major study was the National Council on the Aging report on the consequences of untreated hearing loss in older persons. In a large-scale national survey of older Americans, they quantified the social, psychosocial, and functional effects of hearing loss. Their goal was to assess the effects of hearing loss on quality of life and compare these effects for those who wear hearing aids and those who do not. The self-assessment survey included over 2,000 hearing-impaired persons and another 2,000 family members. The NCOA findings included: most users of hearing aids reported significant improvements in the quality of their lives since they began using hearing aids. Half or more reported better relationships at home and improved feelings about themselves. Many also reported improvements in their confidence, independence, relations with children and grandchildren, and view about life overall. Along every dimension, the family members of the hearing-impaired persons were even more likely to report these improvements. The majority of the family respondents reported that use of hearing aids had resulted in improvements in terms of relations at homes, feelings about themselves, life overall, and the relations with children and grandchildren. Depression, the focus of this webinar, is one of many factors associated with reduced health-related quality of life. Other factors which will be discussed in this webinar including anxiety, which is an emotion characterized by feelings of tension, worried thoughts, and physical changes. People with anxiety disorders may avoid certain situations out of worry. Cognitive disorders are a category of mental health disorders that primarily affect learning, memory, perception, and problem-solving, and include amnesia, dementia, and delirium. Dementia is a progressive loss of cognitive function marked by memory problems and confused thinking. The most common form of dementia is Alzheimer's disease, a fatal condition. A depressive disorder is an illness that involves the body, mood, and thoughts. It interferes with daily life and normal functioning. Self-esteem reflects a person's overall subjective emotional evaluation of his or her own worth. Stress is any uncomfortable emotional experience accompanied by predictable biochemical, physiological, and behavioral changes. Worry is the thought process that increases the feelings and emotions experienced as anxiety. Activity limitation is a difficulty encountered by an individual in executing a task or action. Participation restriction is a problem experienced by an individual in involvement in life situations. Loneliness is a complex and unpleasant emotional response to isolation, where social isolation is a state of complete or near complete lack of contact between an individual and society, and social withdrawal is avoiding people and activities you would usually enjoy, and these are associated with several mental health disorders, including depression. So let's talk about depression. There's a lot we know. There's a lot we don't know. According to the American Psychiatric Association, depression, also known as major depressive disorder, is a common and serious medical illness that negatively affects how you feel, the way you think, and how you act. Depression causes feelings of sadness and/or a loss of interest in activities once enjoyed. It can lead to a variety of emotional and physical problems and decrease a person's ability to function at work and at home. We should know that depression is a chronic disease that must be monitored. The pathophysiological cause of depression is unknown, and there are no laboratory tests or clinically useful biological markers, and the causes are believed to involve a combination of genetic, biological, psychosocial, and environmental factors. There are 14 risk factors for depression, and these are listed on the slide for you. Of these major risk factors, I've highlighted 2 which are directly tied to hearing loss. Hearing loss is a chronic medical condition and often exists with other chronic medical conditions, which is comorbidity. Second, hearing loss, balance loss, and tinnitus onset are stressful events in our patients, and when accompanied by sudden onset, this may amplify the personal stress, especially in younger patients. In looking at depression more closely, let's look at some recent investigations on the relationship of hearing loss and vision loss, which is known as dual sensory loss. I'd like to look at 3 studies which were conducted across 3 countries and involved just under 10,000 subjects. Some of the major findings on dual sensory loss, depression, and anxiety were, from the USA in the Armstrong study, individuals with vision and/or hearing loss reported higher rates of depression, and the prevalence of depression was 31% with a dual sensory loss, 25% with a vision loss, 17% with hearing loss, and just under 12% with no sensory loss. In the Turunen Tahiri study from Sweden, increased depression for dual loss versus hearing loss was also found, with dual loss having an odds ratio of greater than 2 for the presence of depression. In addition, the authors found increased anxiety for dual loss versus hearing loss alone, with adjusted odds ratio approaching 2. Kosh and colleagues from Norway found that the hearing loss group shows depression anxiety effects at baseline, whereas the vision loss and dual loss groups with vision loss show depression effects over time. And they concluded that the different sensory loss groups, that is vision loss versus hearing loss, have different mental health profiles. From these 3 recent studies, hearing care practitioners should be aware that while depression is associated with hearing loss, the presence of vision loss is associated with an even greater risk of depression, and that the combination of vision loss and hearing loss creates an even greater risk for the presence of depression. The clinical importance to these findings to us is that many of our patients come to us with dual sensory loss, and this dual loss of both hearing and vision amplifies the depressive symptoms. Hearing loss is one of many chronic conditions that can occur in our patients. So what do we know about other chronic conditions that are linked with depression in the elderly? Cheng Kwan and colleagues addressed this question in their 2010 meta-analysis of 31 publications concerning 9 chronic diseases and depression. They concluded from their investigation that there were definite risk factors for increased depression in old age for the chronic diseases of stroke, hearing loss, vision loss, cardiac disease, and chronic lung disease, and that there were probable risk factors for increased depression in old age for chronic diseases of arthritis, hypertension, and diabetes. Of importance to us in this webinar, we must always think of our patients' health and wellness and illnesses as more than just hearing loss, Again, we see the association of vision loss with depression is slightly stronger than with hearing loss, and also see that many other health conditions that exist in our patients, such as heart disease, lung disease, arthritis, and diabetes, also impact our patients and their mental health. What else might be of concern regarding depression and chronic illnesses? Gaines and colleagues evaluated depression and its impact on quality of life across just under 10,000 persons in a national database study from the USA. In addition to depression, which was treated as a health disorder, they also evaluated the impact of arthritis, diabetes, and hypertension on health-related quality of life. They found that the presence of depression was associated with poorer health-related quality of life, and that the magnitude of the effect was comparable to arthritis, diabetes, and hypertension. In addition, they found that depression can interact with these other medical conditions to further decrease the health-related quality of life. As healthcare providers, we should be aware that these results underscore the need for us to be clinically attentive for the presence of depressive disorders and the amplification of depression when associated with chronic conditions. Like the Gaines study on depression and health-related quality of life we just discussed, many of the research studies we're talking about have recently been published looking at large databases. In general, these are huge population-based studies that routinely collect public health information over the decades. Currently, these databases are being mined in cross-sectional analysis. In general, the pros of these studies are that the very large databases are for analysis, where we can find statistical evidence for even small clinical effects. And these large databases support complex statistical analysis like stepwise multivariate regression, whereby competing confounding variables such as chronic diseases can be controlled. However, we must keep in mind the cons of these studies, such as the cross-sectional data are only a snapshot in time and often do not include a longitudinal analysis for treatment effects. Also, the data are often self-assessments, which are not the same as clinical assessments. And finally, and most important, we must remember that these are correlations, and they are not to be used to imply causation. One such recent large-scale study was from Lee and colleagues using the USA National Health and Nutrition Examination Survey, known as the NHANES. In this study, with a sample size of over 18,000 adults, many possible variables had to be considered. Of the many covariates in the study, the following were items that were found to be statistically correlated to depression: sex, age, poverty-income ratio, educational level, living alone, self-reported general health status, trouble seeing even with eyeglasses or contact lenses, diagnosed sleeping disorder, body mass index, smoking status, hypertension, cardiovascular disease, diabetes mellitus, and of course the presence of hearing loss. The prevalence of moderate to severe depression was about 6% in the general population, and 11 to 12% with self-reported hearing impairment. Another way to say that is that the absence of moderate to severe depression was 94% in the general population and about 89% in the persons with hearing loss. After accounting for the covariates, hearing impairment was significantly associated with depression, particularly in women and adults younger than 70 years of age. And so hearing care professionals should be aware that an increased risk of depression among adults occurs with hearing loss. And we would be better able to improve the quality of life among people with hearing impairment by recognizing the signs and symptoms of depression and referring patients for mental health services when appropriate. In another large-scale population analysis, Su and colleagues examined the Taiwan National Health Insurance Database for the presence of depression and hearing loss. Their study size was over 5,000 patients with sensorineural hearing loss and another 20,000 patients without sensorineural hearing loss. They found a dozen comorbidities significantly associated with hearing loss, of which 4 were significantly associated also with the risk of depression. These 4 conditions were chronic artery disease, alcohol-related illness, anxiety, and stroke. Where the higher risk of depression was found, it was increased in age and with women more than men. The article states that one of the major reasons this is an issue of public health concern is that unipolar depressive disorders, which is the most common neuropsychiatric condition, and adult-onset hearing loss, which is the most common sense organ disorder, are the first and second leading non-fatal causes of years lost due to disability in high-income countries. However, they go on to say about these large-scale correlational studies, despite a strong association with depression and sensorineural hearing loss, the etiologic mechanisms underlying the relationship between hearing loss and depression are not well established. Effects of hearing impairment include declined quality of life, social isolation, which may lead to depression. On the other hand, some neurotransmitters have been shown to have an impact on depression and on auditory function, and there may be a biomedical linkage between auditory damage and depression via neurotransmitters and neurological pathways. In these large database studies, we've been looking at the correlation between hearing loss and depression. What about depression and treated hearing loss? In another study using the NHANES data, Menner and colleagues evaluated over 1,000 subjects who were in their 70s, who had completed audiometric testing as well as the HPQ-9 results. Their baseline findings were that almost 60% of the participants had a greater than 25 dB hearing loss. Almost 4% of the participants met criteria for a major depressive disorder, and 7% met criteria for any depressive disorder. While greater hearing loss was not significantly associated with greater odds of depression within the group in their 70s, they did find that use of hearing aids was significantly associated with reduced odds of depression, cutting the depression rate by about 40% compared to the non-hearing aid users. Now, in the discussion, the authors point out that this is a cross-sectional correlational study. The direction of any association between hearing loss and hearing aid use and depression cannot be determined. One explanation is that hearing loss treatment may help promote social engagement and thereby reduce depressive symptoms. Or an alternate explanation is that individuals without depression just may be more likely to obtain hearing aids than depressive individuals, and this would produce the same result. There are several studies that have looked at the relationship of treating hearing loss and its effect on depression. For example, Acker and colleagues in Turkey investigated the effects of hearing aids on cognitive function and depressive signs in the elderly. They evaluated 34 patients. Their mean age was 70. Their mean hearing loss was 57 dB. These were new hearing aid users, and they had GDS and MMSE measures pre-fitting and then 3 months post-fitting. The findings were that all patients showed significant improvements in the psychological and cognitive conditions, and that all of them showed betterment of their problems, such as social communication and exchanging information. Their conclusion that was for elderly people, using and being adaptable to hearing aids is a good solution for hearing loss. However, I bring this study to your attention as it represents a common finding in these studies, and one that often is not discussed. Figure 1 on the top left of the slide has the MMSE scores. The mean change in the study was from 20 to 23, 3 points. The score range for mild dementia is 20 to 24. Thus, while the change was statistically significant, the mean scores were still in the mild dementia category after treatment. In Figure 2 on the bottom left of the slide, a GDS score of greater than 7 indicates the presence of depression. The mean score changed from 7 to 5, 2 points. Again, a statistically significant effect, but one where the group mean scores pre- and post-treatment are within the normal range for the absence of depression. Let's look at another study looking at depression and treatment from hearing loss. Castiglione and colleagues evaluated 125 persons who were placed into 6 groups: new bilateral hearing aid users, experienced bilateral hearing aid users, experienced unilateral hearing aid users, experienced cochlear implant users, persons with hearing loss who did not use a hearing aid cochlear implant, and the 6th group, persons with normal hearing. The findings were each treatment group demonstrated improvements after auditory rehabilitation or training on long-term memory tasks, the level of depression, and the cognitive status scores. And auditory rehabilitation for cochlear implants and hearing aids was effective among older adults and enables positive improvements in terms of social isolation, depression, and cognitive performance. Nice findings. However, Figure 1 at the top left shows the digit span test scores at 1-month treatment with bilateral hearing aid users. The mean improvement was from just under 5 to just over 5, where a score of less than 3 is the cutoff for major cognitive impairment. Thus, the mean score for this group was not in the range of major cognitive impairment, but was a statistically significant effect for cognitive improvement. Figure 3 in the bottom left shows the Montreal Cognitive Assessment and the Geriatric Depression Scale at 1-year treatment for the cochlear implant users. The MCOA improvement was from just over 25 to just over 27, where the range of 26 to 30 is considered normal. The GDS improvement was from just under 8 to just over 5, where scores of 0 to 9 are considered as normal. Again, these mean scores were close to or in the normal range. In short, we again see that statistically there are movements in the group means for improvement in mental health with treatment. However, the amount of change is small and generally does not move the treatment group from one performance categorization to an improved level of performance. In a similar study from the USA, Choi and colleagues evaluated the effects of hearing aids and cochlear implants on depressive symptoms in older adults. There were 113 subjects in the study, and their mean age was 70, and as stated, they were treated with hearing aids or cochlear implants. The GDS-15 was used to assess depression, and a cutoff score of greater than 5 indicated depression. Their findings were that the GDS was higher for the cochlear implant group than the hearing aid group at baseline. At 6 months, there were improved GDS scores for both the cochlear implant group and the hearing aid group. At 12 months, there was an improved GDS score for the cochlear implant group that was significant, but not for the hearing aid group. Again, while there was a statistically significant effect for depressive symptoms on the two groups, the individual scores for most subjects was in the normal range. You can see them inside the red box. And the mean cutoff scores for these conditions was not greater than 5, indicating depression was not present in the majority of the people with hearing loss. However, the most extensive improvements in the GDS scores were observed in patients with higher GDS scores. For some individuals, there was a dramatic improvement from the depressive score to the non-depressive score. You can see them highlighted in the blue box, where we see pre-treatment scores of 10 to 13 and post-treatment scores of less than 2. The importance of these findings and the findings of the two previous studies that we've just talked about is that significant depression does exist, but only in a subset of your patients, and they can respond positively to the audiological treatment that you can provide. In addition to studying depression associated with hearing loss, several investigators are also studying anxiety. In two studies, one from the Netherlands and the other from the U.S., anxiety was evaluated for an association with hearing loss. In the Netherlands study, increased anxiety and depression were found and associated with increased rumination and catastrophizing about hearing loss. In the USA study, increased anxiety was found to be associated with increased hearing loss in the elderly. However, these are linkages, and we are reminded that these are cross-sectional studies. From the studies, we cannot establish a temporal link between hearing loss and anxiety. Does hearing loss precede and increase anxiety? Or does anxiety precede and increase hearing loss? Or is there some common underlying unknown linkage that couples hearing loss, depression, and anxiety? We've now seen several current research studies which document the association of hearing loss with depression and with anxiety. Is there a relationship between untreated hearing loss and loneliness? Let's look at two studies, one by Pronk and colleagues from Amsterdam and another by Sung and colleagues out of the USA. The Amsterdam team evaluated about 1,000 persons who had self-reported hearing loss or documented hearing loss for speech and noise. In their database analysis, both groups with hearing impairment showed a significant adverse association with both emotional loneliness and social loneliness. The adverse effect of social loneliness were found in the non-hearing aid users, but not in the hearing aid users. And the adverse effects of emotional loneliness were found in men, but not in women. In the USA study, 145 persons who used hearing aids or cochlear implants were tracked in the Studying Multiple Outcomes After Oral Rehabilitation Treatment, or SMART study through Johns Hopkins. Their findings were that for persons with hearing loss, younger age and greater hearing loss were associated with greater loneliness. In addition, they found increased depressive symptoms, decreased hearing-related quality of life, and increased communication difficulties and poor emotional well-being were all moderately or highly correlated with loneliness. The authors comment that their findings underscore the potential impact of hearing impairment on loneliness in adults and the need to address hearing loss as a potentially modifiable risk factor for loneliness in healthy aging. So can treatment for hearing loss impact loneliness? Weinstein and colleagues in 2016 published study results evaluating 40 adults on the effect of hearing aid use for emotional loneliness and social loneliness. Their findings were also of a significant decline in the perceptions of loneliness following 4 to 6 weeks of hearing aid use. They comment in Figure 3, which is shown in the slide, the proportion of participants who were lonely decreased from 45% pre-treatment to 28% post-treatment. In a similar manner, 55% of the participants were not lonely pre-treatment, and this increased to 73% of the participants post-treatment. While these findings were of statistical significance, we can see again that even in the presence of marked hearing loss, over one-half of the subjects were not lonely, and after treatment with hearing loss, over one-quarter of the subjects were still lonely. Thus, while we can see a very nice treatment effect, we must remember that there are many other demographic, health status, and living arrangement aspects that can impact depression and other mental health factors. The authors conclude by making the case that through intervention, hearing aids improve verbal communications and may restore the possibility for social network, thereby having a positive effect on quality of life and social interactions. At this transition point in the webinar, I'd like to pause and thank the sponsor, Hamilton Captel. We've been talking about how sensory disorders, especially the dual sensory disorder of hearing loss and vision loss, is associated with poor mental health. One path to combat the depression, anxiety, and loneliness is restoration of human communication. As part of your treatment plan for patients, I urge you to consider incorporation of assistive technologies, especially those that can help overcome the barriers associated with both hearing impairment and vision impairment. This should be part of your treatment plan. Let's now look at sudden sensorineural hearing loss. And I'd like to bring your attention to population-based studies out of Taiwan. In the first study, Singh and colleagues evaluated almost 2,000 persons with sudden sensorineural hearing loss against a matched group of almost 7,000 persons without this condition. After going through their statistical analysis, they established that the sudden sensorineural hearing loss patients were more than 2 times at risk for depressive disorders. They also found that this elevated risk of depressive disorder was stronger for younger persons, which in this case was less than 60 years of age. In the second study, Lin and colleagues evaluated 25,000 persons who were diagnosed with depression and a matching number of persons without depression. They also determined the prevalence of sudden sensorineural hearing loss in the population at the baseline and later in time. They found that for persons with depression, they were 1.5 times more at risk for developing sudden sensorineural hearing loss than the non-depressive group. This may be because the persons who had depressive disorders and developed sudden sensorineural hearing loss were noted in patients with diabetes mellitus, chronic kidney disease, and hyperlipidemia, comorbidities. The authors state that these results suggest an increased risk of developing sudden sensorineural hearing loss in patients who have depressive disorders, where several comorbidities significantly aggravate the risk. They then asked the question for further research whether control of depressive disorders can decrease the incidence of sudden sensorineural hearing loss in patients with depressive disorders. Looking at these two studies, sudden sensorineural hearing loss and depression are clearly associated. However, while it seems quite understandable that depressive symptoms may result from sudden sensorineural hearing loss, especially in younger persons, there may also be underlying unknown factors associated with depression which can lead to sudden sensorineural hearing loss. Let's take another look into sudden sensorineural hearing loss. In a recent study out of Korea, Rowe and colleagues evaluated patients' psychological stress for prediction of the treatment response for idiopathic sudden hearing loss. They conducted psychiatric evaluations, both pre-treatment and post-treatment, of 50 patients with sudden sensorineural hearing loss, where treatment was oral prednisone combined with intratympanic steroid injections. 3 months post-treatment, the patients were sorted into one group with recovery of hearing and another group without recovery of hearing. You can see those two groups on the right side of the slide as the individual orange dots in the graph. They found that the non-responder group showed significantly higher levels of pre-treatment depression, pre-treatment anxiety, and pre-treatment stress response. More specifically, they found that 2 factors significantly predicted the treatment response after statistical control for other variables. These 2 factors were the depression subscore of the SRI-MF and the duration of the hearing loss. We know that there are several physiological factors that relate to the recovery from sudden sensorineural hearing loss, such as the person's age, their hearing loss pattern, and associated vertigo. However, the authors point out that none of these factors are modifiable from the treatment process for sudden sensorineural hearing loss, and they recommend investigation into the potential use of psychiatric measures, including stress management intervention, as part of the treatment plan for sudden sensorineural hearing loss. Along the lines of our discussion of possible need for psychological treatment for persons with audiovestibular disorders, Sakagami and colleagues in Japan evaluated 375 consecutive audiovestibular patients for neuroses and depression. The 4 disorders evaluated were bilateral Meniere's, unilateral Meniere's, sudden deafness with vertigo, and vestibular neuritis. Their findings for neurosis and depression were the highest for bilateral Meniere's, which was higher than unilateral Meniere's, which was higher than sudden deafness with vertigo, and then vestibular neuritis. Their conclusions were that mental health disorders increased in progressing from solo vertigo, vertigo associated by hearing loss, and presence of repeated symptoms, and then bilateral loss. They recommend that in order to avoid development of a psychological disorder, various treatment strategies must be considered for patients with persistent nystagmus, a history of prolonged disease duration, and/or hearing loss in the secondary affected ear. Regarding psychotherapy for depressive disorders, there are medical guidelines for the treatment that are evidence-based, and these include dual but competing approaches. For mild to moderate depression, either a psychological approach of talk-based therapy or a biomedical approach using medications may be successful. For severe major depressive disorder, the use of medication is recommended with or without psychotherapy. In terms of the type of therapy that's used, cognitive behavioral therapy or some form of CBT is frequently used and successful. I find this duality of successful treatment outcomes fascinating, with possible implications for us in understanding and treating depression associated with hearing loss. These two modes of treatment are following two totally different paths. One is communication-based therapy, and the other is biological-based medications. Knowing that this duality exists, we must be aware that depressive symptoms in our patients may have an underlying cause that is hearing loss, leading to communication impairment and isolation and depression. But the underlying mechanism may not be related to the hearing loss, and something else may be in play regarding the depressive symptoms. I hope you're coming to realize now that the presence of depression coinciding with hearing loss may be directly related, indirectly related, or not related at all. I'd like to look at some recent modeling by Rutherford and colleagues in their article on Sensation and Psychiatry, linking age-related hearing loss to late-life depression and cognitive decline. What's displayed is Figure 1 from the Rutherford model, and it presents a multimodal representation of the clinical and behavioral mediators linking age-related hearing loss to neuropsychiatric dysfunction. Now let's examine both a downstream or audiology-based explanation and an upstream, a neuropathology-based explanation. Rutherford describes a possible downstream impairment model as follows. The pathophysiology of hearing loss encompasses both degenerative changes in the inner ear structures and altered neural processing of auditory input. Many hearing-impaired older adults avoid or withdraw from social contexts in which background noise will make it difficult to communicate, resulting in social isolation and reduced communication with family and friends. Social isolation has been linked to reduced quality of life as well as numerous adverse physical and mental health outcomes in older adults and to the development of depressive symptoms. Rutherford also describes a possible upstream impairment model as follows. Upstream common causes such as inflammation, vascular pathology, and other systemic neurodegenerative processes may lead to hearing loss, depression, and cognitive impairment via central nervous system-wide functional decline. In addition, neuropathology studies have reported the presence of pathophysiologic features of Alzheimer's disease, such as plaques and tangles, in multiple central auditory regions, such as the cochlear nuclei, inferior colliculi, thalamus, and primary auditory cortex, while sparing the peripheral structures. In terms of treatment for our patients, Rutherford states, the obvious therapeutic implication for the reviewed evidence of the association of age-related hearing loss, cognitive decline, and development of late-life depression is to treat the hearing loss to avoid these adverse outcomes. An appropriately fit hearing aid amplifies speech for improved communication, resulting in improved psychosocial functioning and quality of life. Emerging evidence suggests the positive effects of restoring auditory input using hearing aids or cochlear implants extends beyond improved hearing to better cognitive functioning and reduced depressive symptoms. Figure 3 extends the previous model we looked at to look at targets for therapeutic intervention who are at risk for neuropsychiatric dysfunction. We know that age-related hearing loss can eventually have a downstream effect on the central auditory circuits, and this may have secondary effects on both the cognitive control network at the top of the figure and the limbic system, which at the bottom of the figure, which then have downstream effects promoting neuropsychiatric dysfunction, including depressive disorders. The cognitive control network manages the executive functions, making it possible to play with ideas, including attention, reasoning, creativity, task switching, mental flexibility, and working memory. Historically, the executive functions are seen as regulated in the prefrontal areas of the frontal lobe. Now, the limbic system supports a variety of functions, including emotion, behavior, motivation, and long-term memory. And it's a complex set of structures that lie on both sides of the thalamus. Just under the cerebrum, it includes the hypothalamus, the hippocampus, the amygdala, and several other nearby areas. Rutherford suggests that in combination with restoration of hearing, it may be additionally valuable to target the neural mediators and behavioral outputs to maximize the individual's functionality. For example, computerized cognitive training might be used to target the executive dysfunction in older adults with hearing loss. And treatment with antidepressant medications has been shown to successfully target limbic activity. Evidence-based psychotherapies, such as cognitive behavioral therapy, may improve emotion regulation by augmenting the lacking top-down modulation of emotions. When I look at all of this, I see a very near future of audiologists and psychotherapists working to co-manage the patients we've been discussing in this webinar, with the audiologist responsible for amplification and cognitive remediation training, and the psychotherapist responsible for therapy and medication. Now that you know that depression is a significant obstacle to the quality of life, depression is present and may be widespread in the population, and depression has an increased prevalence in persons with vision impairment and hearing impairment, should you be on the alert for depressive disorders in your patients and screen for depression? The answer is an unequivocal yes. McCarran and colleagues writing in Annals of Internal Medicine tackle the topic of depression in the clinic. They state, clinicians should consider screening patients with identifiable risk factors. And we know that two risk factors are chronic comorbid conditions and recent stressful events. They recommend use of the PHQ-2 as a screening tool for depression. It is widely used and is an efficient screening tool. The self-administered test has two questions. 1. Over the past 2 weeks, have you felt depressed or hopeless? 2. Over the past 2 weeks, have you felt little interest or pleasure in doing things? Patients with a yes response to one or both of the questions has failed the screening. If you are interested, a more in-depth screening can be done with the 9-question PHQ-9. The PHQ-9 is commonly used in primary care populations. It is easy to use and has good sensitivity and specificity. It is both a diagnostic and severity rating instrument, and the slide shows the link for both the PHQ-2 and the PHQ-9. So let's start bringing this webinar to conclusion. Depression is present at 5 to 10% of the population and may be prevalent up to 40% in some populations. There are many contributors to depressive symptoms and major depressive disorder, including genetic, psychological, and environmental factors. Chronic diseases are strongly associated with depression, including asthma, arthritis, cardiovascular disease, cancer, diabetes, and obesity. And the chronic diseases of auditory and vestibular pathologies are known to be associated with depression. Reduction in depressive symptoms can occur with auditory rehabilitation, and positive results include reductions in depression, worry, anxiety, loneliness, emotional isolation, and social isolation. In moving forward, I recommend that audiologists should consider screening for and considering co-management of depression with mental health professionals. And in looking to the future, coming research may identify underlying biomedical linkages between depression and hearing loss with a common medical cause contributing to both. If you are so inclined to follow up on this webinar to learn more about clinical depression, here are 2 articles that I would recommend to you. The first is Depression, an in-the-clinic guidance document from 2016, which can be found in the Annals of Internal Medicine. The second is Hearing Loss, the Silent Risk for Psychiatric Disorders in Late Life, a 2017 publication which can be found in the Psychiatric Clinics of North America. So let me leave you with this one way to think of depression. Depressive disorders can be thought of as a system of streams and waterways with flow into the mental health river, which is kind of fun to use as an allegory, as streams and rivers do actually flow through geographic depressions, which are low points in our landscape. All of these streams contribute to the combined flow into the river's health, just as many physical, emotional, environmental, and neuropsychological factors can contribute to mental health. As long as all these streams are functioning normally, the river does not flood. But any one stream or combination of streams can become overloaded and result in the river flooding, causing damage. Depression associated with hearing loss is certainly one stream that can overflow in the waterways of depressive symptoms, and we know that treatment for hearing loss can lower the level of depression. So the awareness that we must have is that depressive disorders exist in some of our patients, And the good news is that we can certainly help alleviate depressive disorders through auditory rehabilitation. And when indicated, we can choose to include possible co-management strategies with mental health professionals for these patients in need. I'd like to thank you for your time today. I hope the last hour has been informative and beneficial for you. I'd also like to thank Carl Strom and the Hearing Review, and our sponsor, Hamilton CapTel, for making this webinar possible. And I wish you the best in your treatment of your patients, and I hope that you continue to add value to their lives and improve their quality of life. Goodbye and good day.
Thanks for that great information, Dr. Bray. Dr. Victor Bray is a PhD audiologist and an associate professor at Salus University's Osborne College of Audiology in Elkins Park, Pennsylvania. If you have any questions for Dr. Bray, you can email him at the address shown here. This webinar was brought to Hearing Review courtesy of Hamilton CapTel, a company that offers caption telephones to help people with hearing problems stay connected. For more information about their great offerings, you can visit hamiltoncaptel.com/HHC. Hamilton CapTel will also be offering a related white paper for this webinar that will be available via a link at hearingreview.com. I'd like to thank Dr. Victor Bray and Hamilton CapTel for their participation in this webinar, and also Hearing Review staff members Eli Patterson and Roy Phelps for their help in producing it. For the Hearing Review, I'm Carl Strom. Thanks for watching.